Prosthetic joints occur in about 1 to 2% of all arthroplasties across the globe and about 4% of revision arthroplasties. And if you see the graph on the right side, this is taken from the review by Robin Patel and NHM earlier this year. There has been a huge increase in the numbers of these surgeries being performed over the last couple of decades. So not only does this add to the numbers of prosthetic joint infections that occur, also there is a very huge healthcare burden of about $1 to $2 billion that occurs per year in the US alone. I've been asked to talk a little bit about biofilms as well. So we will just quickly look at what is the pathogenesis of a prosthetic joint infection. So the first acquisition of infection usually occurs at the time of surgery, at the time of incision, either from an adjoining surface or from settlement of organisms from the air. Once that happens, there is local recruitment of neutrophils, followed by phagocytes and macrophages. And then there is an antecedent increase in the inflammation and inflammatory markers like white count, RBC, and C-reactive protein, which occurs at the point of infection. And this basically leads to the symptoms of pain, redness, swelling, etc. And as a result of this inflammation, there is also recruitment of bacterial genes to upregulate their toxins. So bacterial exotoxins are released at this point of time, and these toxins are usually able to stimulate osteoclasts that will resorb the surrounding bone. And because of that, the implant which is present over there starts loosening up. And moreover, because there is absence of vasculature on the implant, there is not much more recruitment of immune response locally, and bacteria are able to survive and thrive. And once enough mass of bacteria is obtained, they form something known as the biofilm. They do this by recruiting adjoining organisms and also secreting something called as the extracellular matrix. And this protects these organisms from any further immunity of the host as well. So, and this frustrates the immune response further, and there is effectively a physical barrier that is now formed, that is a barrier to antibiotics as well. So the way a biofilm is formed is basically it starts off with planktonic organisms which are not associated with the biofilm, first attaching to the surface. In this case, it's an implant, and there is a local multiplication of organisms leading to the formation of a microcolony. And these organisms will secrete what is known as the extracellular matrix, which is composed of polysaccharides as well as extracellular DNA, which basically makes it a really rugged surface that becomes really impenetrable. And once this reaches a critical mass of biofilm, these organisms are again able to disperse from there and release planktonic organisms, and the cycle sort of continues. So some of the challenges to the clinician as well as the patient in terms of biofilm formation, apart from the inadequate immune response, is that the amount of drug that is needed to reach the site of infection is much, much higher in case of a biofilm. That is quantified by the minimum biofilm eradication concentration, which is at least 10 to 8,000 fold higher than that of the MIC. So there is a need to expose this infection to high dose and duration of antibiotics, and the location is also very important. Also, since there is a big group of organisms living in the biofilm, there can be a high quantum of drug degrading enzymes like beta lactamases in the biofilm setting. And once the biofilm is formed, it is able to recruit many other bacteria also, and this contributes to the larger community as well. The classical infecting organisms in prosthetic joint infections can be divided into organisms that cause early onset infections, that is within 3 months of surgery. And this is usually caused by organisms which have high virulence potential and increased virulence factors. And most commonly, this is Staphylococcus aureus and in certain cases, aerobic gram-negative bacilli as well. The late onset organisms that occur in infections greater than 3 months, between 3 to 12 months or greater than 12 months, are the less virulent organisms, which are also common commensals like coagulase negative staphylococci and enterococci. However, this is not set in stone, and there have been several instances where coagulase negative staph can also cause early onset infections, especially Staphylococcus lugdunensis is well implicated in several early onset PJIs as well. So there is actually very little Indian data that is available in literature. In fact, it is only one single center study from AIIMS Delhi that has reported about 106 patients of PJIs over a period of 4 years. I have here just compared this data with that of another big single center study from the Mayo Clinic, which has looked at around 2067 episodes from 1651 patients. So some interesting observations here are that the culture positivity in Mayo Clinic is much higher at 95% versus 79% in the AIMS report. And the number of the main important organism causing infection as a single organism is Staph aureus in the AIMS study, whereas it was coagulous negative staph in the Mayo Clinic study. But probably the most important point to be taken away from this table is the most common group organism in the Mayo Clinic versus AIMS Delhi, which is aerobic gram-positive bacteria causing 82% of the infections in Mayo Clinic, whereas in the AIMS study, it was 61% caused by gram-negative aerobes. So here there is a predominance of gram-negative aerobes versus gram-positives in comparison to international literature. Couple of other things to note in this comparison between the international data and the single center studies from Mayo Clinic and AIMS is that the isolation of anaerobes in Mayo Clinic and even internationally ranges up to around 10%. Here it was 13%, and of which 8% was Cutibacterium acnes, whereas in the AIMS study there was no isolation of any anaerobes, and also the fungal isolation was nil, whereas it can range between 0 to 1% internationally, and this is mostly attributed to Candida species. In the Indian study, they looked at the drug resistance profile also, although the number of isolates you see here is quite less, that is 84 number of isolates only, and individual species numbers were also very few. But if you look at the ESBL percentage among Klebsiella and E. coli, it was 100%, which means that none of these bugs responded to ceftriaxone or other third generation cephalosporins. For Pseudomonas, the Pipta's resistance was about 38%. The MRSA rate was about 28%. So apart from these garden variety organisms that have been reported in these large single center studies, there are several case reports that you will find even in the Indian literature, including organisms like Cutibacterium acnes, which is a bug of a lot of interest, especially in the Western literature, especially with respect to shoulder replacements, but also with other joints as well. There are case reports of non-tuberculous mycobacteria like Mycobacterium abscessus that have caused joint infections. They cause very difficult to treat recalcitrant infections. And in a place like India where TB is endemic, it should not be forgotten, even though it is a device associated or a prosthetic device associated infection. You can always end up finding TB when you are not looking for it. And fungal PJIs, including Candida species, have been reported as case reports. About 10% of the prosthetic joint infections, according to the MSIS criteria, can actually be culture negative for various reasons. Most commonly in an Indian context, you would think of prior antibiotic use or previously unrecognized causes of prosthetic joint infections. And there may be differences in the way that sample is collected and transported. And the methodologies that are used by different labs can be really different. Like, for example, some labs use the automated blood culture systems to culture synovial fluids also, whereas some don't. And improper use of available methods can also lead to culture negativity. So finally, here are the take-home points from this talk. With respect to prosthetic joint infections in India, we have very limited data that is available, and all this comes from single center studies and case reports alone. So there is a pressing need to actually perform multicentric studies and generate large-scale data, which I think as this forum of Arthroplasty Summit, we can actually plan for studies like this. And in the Indian context, just like we do with other infections, it is important to also think of gram negatives, especially even in the early onset prosthetic joint infections, and the possibility of drug resistance, including high level of ESBL and also to a large extent carbapenem resistance need to be kept in mind. And possibility of culture negativity can actually be much higher in India than other in the West, because we have rampant usage of antibiotic therapy already consumed by the patient before they present to us for diagnosis of infection. And molecular diagnosis, of course, is the way forward. And we have several syndromic panels now available. Metagenomics and next generation sequencing is being increasingly used, and this is going to be the way forward. So thank you so much for this invitation, and I'm available to take any questions.